And his
Thank you very
title,
much for your kind invitation
okay.
and allowing me to speak at your conference. I was due to join you and, in fact, actually had a plane ticket arranged, but unfortunately, due to changes in timings, I was unable to join you. So I hope in the future I will be there with you at future conferences, but today I'm going to present this virtually. So today I'm going to talk about high intensity focused ultrasound and try and show you that certainly for some varicose veins, it's already becoming an easy and useful method to treat them. I have no disclosures relevant for this presentation. So just the same as when we were bringing endovenous surgery into the world in 1999, there were many people saying that it would never work, it was far too slow, it was too expensive, and nothing would replace stripping. And we now know 20 years later that was completely incorrect. And I think we're going to see the same story panning out with high intensity focused ultrasound. So before we start getting into is it better or worse than endovenous surgery, we first of all have to think about what is it we're actually treating. So when we think about patterns of varicose veins, we often revert to those patterns that we were taught at medical school. The very simple reflux in the great venous vein using gravitational reflux and incompetence into the varicosities, or of course the similar small venous vein truncal reflux. However, we're becoming more aware that incompetent perforating veins are very important in the pattern of varicose veins, whether they're here as part of the venous reflux with the truncal veins, or indeed whether they're found separate, causing varicose veins, thread veins, venous edema, or even C4, 5, and 6 disease. Another common cause of varicose veins, thanks to previous years of open surgery and stripping, is the neovascular tissue or strip tract revascularization, which can have varicosities or the other forms of venous hypertension. Or, of course, the thing that looks like this in patients who haven't had surgery, the parva tissue, which we described a few years ago now. So looking at the different patterns of varicose veins, the truncal venous reflux is probably the easiest to understand, and it's certainly the one that is the most basic and the one that's taught at medical schools. And this is the truncal venous reflux, usually the great venous vein, sometimes the small venous vein, sometimes both, occasionally the anterior accessory venous vein going into the varicose veins. And although this is the most easy to think about, it actually is one of the more difficult ones for the high intensity focused ultrasound because of the long vein and the fact that the whole lot needs to be ablated unless you follow the hemodynamic surgery principles. Of much more interest to us at the moment is the increasing number of patients we're seeing who, with correct diagnosis, either have truncal venous reflux that is associated with incompetent perforating veins, or incompetent perforating veins alone causing C1, C2, C3, even up to C6 disease, but with competent trunks. Now, doctors who believe in hemodynamic surgery will often tell you that any large perforators lower in the leg associated with truncal reflux are just re-entry perforators, but they then are unable to explain how we see the disease that we see in the lower limb when we have isolated perforators or groups of perforators. And it's clear that this sort of active reflux in these perforators is in fact a source of varicose veins and venous disease in its own right and doesn't have to be associated with truncal venous reflux. The importance of incompetent perforators and whether they should be treated in patients with varicose veins was the subject of a transatlantic debate in which I debated with Thomas O'Donnell from the United States, and this debate was published in 2014 simultaneously in Europe at the European Journal of Vascular and Endovascular Surgery, as well as in the Journal of Vascular Surgery in America. And if you're interested in this area, and particularly if you currently are not treating or thinking of treating perforators, I would recommend you look at this and look at the references. There are increasing numbers of papers, but this one is from our own unit that is due to be submitted for publication, but was presented as a poster at the recent UIP in Istanbul. And in this, we showed that when we looked at 22,000 limbs, we were able to draw conclusions between reflux effects in truncal veins and those in incompetent perforators. The first thing that we were able to show was that increasing the number of perforators was associated with an increasing severity of disease using the C part of the CEAP score. This isn't new, but it's certainly one of the biggest series to actually prove it without a doubt. However, much more significantly, we were also able to show that the effect of 2 incompetent perforators by themselves was equivalent in terms of severity of disease to 1 great saphenous vein refluxing, and 3 incompetent perforators was equivalent to both a great saphenous and small saphenous vein reflux. And for this reason, we now know that incompetent perforating veins are very important in the progression of venous disease, and leaving them untreated is obviously a mistake. Finally, for this group of patterns we're talking about is the neovascular tissue or the varicosities, usually due to previous open surgery. Although many will attempt to close this with foam sclerotherapy alone, my colleague, Professor Barry Price, has shown this very eloquent way of closing these using endovenous surgery and what's called the hedgehog technique, with multiple areas of insertion to get as many of these veins ablated as possible using thermal ablation. However, everything started to change back in 2019 when we took delivery of our first Sonovane machine, which is now we call the Sonovane 1. And this rather bulky machine here was introduced into our London clinic initially in about May 2001. And this is a photograph of us treating one of our first patients. For those of you who are unfamiliar with high-intensity focused ultrasound, I'm just going to walk you through the basics of the Sonovane machine that's made by Thoracian. When we look at the head of the treatment head of the machine, we have 2 different forms of ultrasound. The first here is a grayscale or linear array that gives us a grayscale image of the area we want to treat, but it also has color flow Doppler capabilities to look for flow in any of the vessels. The second ultrasound component is this dome-shaped area here, which is a transducer in a dome which produces ultrasound which travels through the tissues as a cone and focuses at a point approximately 5 to 6 centimeters deep inside the tissues. Now that is a fixed focal length, and so you may think, how do we know exactly where that focal point is going to hit, and how can we aim it onto the vein? Well, the answer to that is this whole head is surrounded by a balloon here, which is filled by a pump with cool fluid to keep the skin cool, but also at a certain pressure, this holds the tissue at a certain distance away from the transducers, both the imaging transducer and the treatment transducer. Now, by changing the pressure of that, we can do all sorts of things. We can actually move the vein closer or further away. We can, of course, move the robot arm as well. But when we want to treat the vein, we can also reduce the pressure, first of all, to see the vein, and that will allow the vein to open. And then when we want to treat the vein, we can increase the pressure. We can force that vein to shut, so there's no blood flow in it, and all the heat that is then formed by the high-intensity focused ultrasound is concentrated in the vein wall. And we'll see a video of this shortly. So this is a simple diagrammatic view of that treatment head, and here we're seeing the 2-dimensional grayscale ultrasound here, and with the Sonovane 1 we used to have to put this local anesthetic targeted around the vein, and this is a typical sort of thing that we were seeing back with Sonovane 1 in 2019. When the grayscale had imaged the vein and we were certain we knew exactly the point we had to treat, we were then able to fire this domed array, and this would give a cone of high intensity focused ultrasound focused at this one point where we would get the ablation and the thermal effect of the ultrasound. The result of this was then to see gas bubbles from the ablated tissue, and this is called the hyperechoic marker, but it's actually little gas bubbles within the tissue, within the vein itself, showing that we've elevated the temperature of the vein and we've caused destruction of the tissue. This is a machine with an exit. You can see this is focused on a small vein, patient live probe. Treatment vein.
Have you pulsed and the blood comes, say stop straight away if you feel anything?
Vein. It's called
How's that feel?
With that original Sonovane 1 machine, it took 1 minute per pulse, and that was 8 seconds or 4 seconds to actually have the heating effect, but then a cooling time of approximately 40 seconds, which really made it a very laborious and slow treatment. So although Sonovane 1 did work and the pulses were effective, and as we've presented previously, we got good ablation rates of the veins we treated, it was so slow it wasn't really a viable treatment for any but the most special patients who really wanted to have it done or had the most minor disease. So Thuraklian then brought out Sonovane S, a much more speedy way of performing Sonovane, hence the S for speed. The major difference was that the pulses were 0.5 seconds or 1 second in duration, with a cooling time of 6 to 8 seconds, which meant that each pulse went from being a minute to only 6 to 8 seconds. So instead of doing 1 pulse per minute and still looking for the vein, we were able to perform 5 or 6 pulses per minute. This was a tremendous increase in speed of treatment. This is a S action hit one pulse coming, and you can see how quick the pulses become. You can see that's the target vein, but a targeted local anesthetic around it is another pulse coming. And you can see how quick not only the pulse comes, but also how quick this cooling effect happens, allowing the second pulse to come straight afterwards. So this was clearly a much faster technique with the Sonovane S, although we were still using some form of injected anesthesia around the vein for most patients at that stage. So in August this year, we took delivery of the latest version of Sonovane, which is Sonovane HD. And this really is a huge advantage over the previous Sonovane 1 and even the Sonovane S. And I'll run through this briefly now. With the Sonovane HD, we get far better imaging. The imaging is much better, both grayscale and color scale, so that we can actually see everything we're looking at with much more clarity. More importantly, we don't have to change over from one probe to another. Physically, there's a software changeover, so you can go from treatment head to diagnostic probe and back again. We found we can preload our patients with oral non-steroidal anti-inflammatory, one called Nefapam. And if we do that about 20 minutes before treatment, very, very few of the patients need any local anesthetic at all. So most are now having treatment of truncal veins or perforators with no local anesthetic injections whatsoever. Those that do need it don't need targeted local anesthetic anymore, but we do a very, very small amount of peri-adventitial anesthesia, so little that you can't even see it on the ultrasound once it's diffused within a couple of seconds. This is a compilation video looking first of all at taking the pressure off the balloon, and you can see in the middle here the great venous vein opening. Putting the pressure back on, we can see the vein closing again, getting all of the blood out of the area, and then we can treat the vein wall with a half-second pulse. And 2 or 3 of those will start closing that vein so that we can then start working down the vein itself. Yeah, exactly. You can actually see not only the HEM, the hyperechoic marker, but if you saw very quickly, you can even watch the tissue contract, and you can see the effect of the closure of these perforators. So with the high definition ultrasound, we can see the perforators so clearly, We can use colour flow to see flow in them. We can then treat them with about 6 to 8 pulses, and straight afterwards we can see that they're occluded. So incompetent perforating veins are very, very accurately treated and very quickly, with no need for scrubbing up or introducing any needles into the veins at all. We're also now treating really quite complex neovascular tissue, particularly in the groin, where people have had previous open surgery, and we can see all the different vessels in the groin. And by starting with the HIFU and starting at the saphenofemoral junction, or wherever the leak is coming from where the tie had been, and working our way outwards along each of the vessels, we can get a very good thermal ablation closure without doing any incision into this area, without disturbing it, and in many cases with minimal, if any, local anaesthetic at all. So this really is an ideal way to treat what is otherwise quite a hostile groin with a lot of scar tissue. So, Mr. Chairman, ladies and gentlemen, in summary, high-intensity focused ultrasound is thermal ablation. We're heating the tissue at the specific point, and we know we're heating it to a level that is going to kill the cells and cause thermal ablation without any carbonization. So, although it's not endovenous, it's not within the vein itself, we know the principles of thermal ablation work, provided we get the right amount of energy into the right volume of vein. So, we're on a good starting point to have an effective technique. When we then look at anaesthesia, most of the patients with the Sonovein HD and even with the S now don't need local anaesthetic at all. Those that do, it's very easy to inject under the cold balloon, and patients don't really feel it very much, particularly if you use a very small needle like an orange or 29 gauge needle. Nowadays, we only use a very small amount of concentrated 1% or 2% local anaesthetic, and we just inject a very small volume peri-adventitially. And this allows the vein to stay open, and it allows us to use the different tricks of either using colour flow or to squash the vein to see it wink or open and close with the pressure, so we can identify the vein and see when it's eventually ablated. We've already found that when we look at timings of getting patients into theatre, out of theatre, scrubbed up, etc., we're finding equivalence between endovenous surgery and Sonovein, which of course does not need any of that preparation. So therefore, Sonovein is at least as quick, if not quicker, for the treatment of incompetent perforating veins and for neovascular tissue in the groin. Without doubt, it is still slower for isolated truncal vein ablation due to the length of vein that needs to be ablated. And without doubt, once you get over about 5 to 6 centimeters, then the Sonovein is much slower because you have to go along hitting each individual point of the vein at the way we're doing it at present. However, it must be said that the speed is improving considerably, as I've already shown you, and there are some new developments coming which is going to speed it up even more. So in conclusion, Mr. Chairman, ladies and gentlemen, high intensity focused ultrasound is definitely easy and effective, and probably the selection of choice at the moment when treating varicose veins secondary to incompetent perforating veins and neovascular tissue. It is effective but takes longer than the endovenous thermal ablation techniques. When we look at truncal veins, if a section needs treatment more than about 5 to 6 centimeters. Less than that, there's an advantage to the high intensity focused ultrasound, as you don't need theatre, you're not being invasive, and patients can still wear their outside clothes, and this can be performed in an outpatient room without need for any sterility at all. However, because of the speed of the thermal ablation devices once they're in the vein, once you get over 5 to 6 centimeters at the current time, the high intensity focused ultrasound starts taking longer and longer, the longer the vein is. However, having said that, things are moving, and we are increasing the methods to increase the speed of treatment. More importantly, it is a walk-in, walk-out technique with no needles, nothing inside the vein, and certainly in this time when patients are very worried about infections and things being both in the body, but more importantly in their vascular tree, we're finding more and more patients are now coming and saying, I accept a higher price, I accept maybe more treatments and more time to come to treatment, and certainly longer treatments, provided I can have something that's totally non-invasive. So I think we're going to start finding that HIFU becomes the patient choice for the treatment of varicose veins. Thank you.